Okay.
Start the introduction again, Nikhil. Okay. So,
Shorten it some more.
okay, sir. Okay. Okay. So, welcome to Crohn's and Colitis Pod. Today, we have a very special guest with us, Dr. Kishore Alapati. He is a senior consultant, colorectal surgeon at Institute of Colorectal Surgery in Apollo Health City, Hyderabad. Prior to this, he was at the same post at Global Hospital, Hyderabad. He was an attending surgeon at Genesis Hospital, US, Illinois. He is board certified in both colorectal and general surgery. He is a member of several associations, which includes American Medical Association, American College of Institute Surgeons, Indian Medical Association, and Association of Surgeons in India. His interests majorly includes laparoscopic technology, transrectal and transanal surgeries, pouch procedures, sphincter surgeries, video-assisted anal fistula treatment, and many more cutting-edge technology in the field of surgery. I welcome you, sir. Thank you for being the part. Okay, so the very first question is, what is an ostomy and what are the different kinds of ostomies?
Right. So ostomy is anything where we have connected any part of the intestine to the wall of the abdomen. Okay. So if you connect a stomach to the wall of the abdomen, we call it a gastrostomy. If you connect the food pipe, which is the esophagus, to the skin, then we call it an esophagostomy. Similarly, if you connect the small intestine to the abdominal wall, so a bit, if you go into a little bit of a technical detail, the entire length of the small intestine is roughly about 20 to 25 feet,
Okay.
20 to 25 feet, right? Of that, the first 10 to 12 feet is called the jejunum, and the last 10 to 12 feet is called the ilium. And if we were, for one reason or the other, bring the first 10 to 12 feet part of the intestine and attach it to the abdominal wall, then we call that a jejunostomy. If we connect the ilium, any part of that last 12 feet of the small intestine, ilium, to the abdominal wall, then we call it an ileostomy. Or if we connect any part of the large intestine or colon, then we call it a colostomy. So any segment of the intestinal tract that artificially, as a surgeon, we connect it to the skin, or technically speaking, to the skin, and it's draining out through the skin. That is an ostomy, which is, the name given after whatever the part of the intestinal tract is connected to the skin or the abdominal wall. Right.
So, can you explain urostomy also, in which we have a urine bag?
Right, right. So exactly. So if for one reason or another, some patients are having cancers of the bladder and things like that, then there is something called a ureter, which is the tube that comes out from the kidney, which originally connects to the urinary bladder. And so if for one reason or another the bladder is removed and there is no storage bag to pass the urine through the normal opening, then we connect that ureter, or the pipe that drains urine from the kidneys, to the stomach wall, and that is called a urostomy bag.
Okay. And so, how it is created surgically, like any kind of ostomy, how it is created surgically?
Right. So for anything, obviously, you will need to go into the cavity. So we make a cut if it is an open surgery. If it is a laparoscopic surgery, we make small keyholes to enter into the stomach cavity. If it is robotic surgery, we make even smaller keyholes to enter into the stomach cavity. Do whatever, everything that needs to be done inside the abdominal cavity, remove the organs, get them out. And then once you have that thick layer of the stomach wall, where you have, the layers of what we call the fascia, muscle, and skin, then you make an artificial hole
Okay.
out of these muscle layers, right? So if this is the inside of the cavity and this is the outside, then let's imagine this is as to be the ilium. Then the ilium is brought out. We put an instrument, a surgical instrument, grab onto the intestine, bring it out gently, making sure that it maintains its blood supply, so it doesn't have any problem in regards to that. and then this is brought out, and the edges are stitched all around to the skin, so that if you were to look at it, the textbook, in the surgical textbook, describe it as, if you have done a stoma properly, then it should look like a rosebud,
Okay.
right? It should nicely flower out like that, right?
Okay. Okay. So the very next question is: under what circumstances does a person need to undergo ostomy surgeries?
Right. So, if there is an surgical emergency in the abdominal cavity, wherein there was a perforation, or what we call a rupture, perforation, or plain English is a rupture of the intestine, whether be it the small intestine or the large intestine, and there is plenty of infection within that had collected within the abdominal cavity, and then more or less the patient is sick, and we need to proceed as an emergency operation. Almost 100% of the times we will remove or cut out the section of the intestine that is causing the problem,
Okay.
be it a perforation, meaning be it a rupture, or be it a tumor that is blocking it completely. So whatever the reason is, that section of the intestine which is causing the trouble is cut, removed completely, and then the end that is above the section that we have removed, that end is brought out as a stoma,
So
right?
in all the cases, we have to do, we have to create a stoma and make it a ostomy, or there are some other cases also. Like in every case, we have to make a ostomy if we take out that part.
No. Now, with the current technology, and we use biometric technology that we have, a good number of times, a very good number of times, we will be able to reattach the intestines back together. Okay, that's number one. And number two, what I would like to say is, even if in an emergency we end up creating an ostomy in these patients, whether it is the small intestine as an ileostomy or the large intestine as a colostomy, we wait for them to recover completely, which typically takes anywhere between 6 to 8 weeks or a 6 to 12 week window. So wait for that infection to settle down, wait for the body to recover out of that acute episode. And then a good number of times, meaning statistically also, if you were to look at it data wise, which is published data, about 80 to 90% of those patients can go back, have another operation, and have the intestines reattached back together. Okay, so that means that a good number of times the stoma, whether it is a small intestinal stoma or the large intestinal stoma, is reversible.
Okay.
And the only time when it is an irreversible ostomy is when you have a colostomy, right, where the large intestine on the left side is brought out and put out as a colostomy, and the entire rectum, along with the muscle,
Splinter muscle.
sphincter muscle, is removed completely, and the bottom end is stitched closed shut completely. That is the only time we will call that a permanent stoma. Rest of all the times, depending on the patient's health and the availability and the technicality and the possibility, most of the times we would be able to reattach back the ends back together.
So in the context of inflammatory bowel disease, how effective is ostomy surgery as a treatment option?
Right. So we do a lot of IBD surgery in our colorectal institutes in Apollo. I think, as a matter of fact, we're probably the team which does every single known operation for IBD, be it Crohn's disease or be it ulcerative colitis. Me and Dr. Matai, my senior colleague surgeon, both of us in partnership, we do it all together. And the, the chances of doing an ostomy in patients with IBD, Crohn's disease, relatively less, unless otherwise, like I said, if it is a catastrophe in the cavity, whereas where the intestine is ruptured and, plenty of pus, half liter, quarter liter of pus is in there, and patient is sick, low blood pressures and severe infection. Then we don't have a choice. To save the patient, we go in, remove, clear the infection, stoma, come out. In ulcerative colitis, the chances of ostomy is a little higher compared to Crohn's disease, because as you all know, Crohn's disease is something that affects the small intestine almost about 80 to 90% of the time, whereas ulcerative colitis is a disease that affects the colon 80 to 90% of the time. So because ulcerative colitis tends to involve the colon more predominantly, the chances of being or chances of us having to perform a stoma or an ostomy in these patients with ulcerative colitis is a little higher compared to Crohn's disease.
So, if circumstances permit, what preparation is required from the patient prior to the surgery?
Right. So the only preparation is usually wash out of the intestine. Right. There are a couple of different medications that we use. There are a few powders and a few liquid forms that we do. So the day before, we typically ask all of our patients to stay on liquid diet. So no solid food. In that way, one way we're converting all the effluent or the stool that's forming into liquid stage. And then on top of that, we put them on this laxative medicine, which would probably make the patients go to the bathroom or to the toilet about 8 to 10 or 8 to 12 times, wherein the last 4 or 5 bowel movements will almost be in the liquid phase, right? So what's important for us is not really the intestine being washed out completely, because nobody ever can do that. There is always some amount of stool that's always left behind, no matter what, right? So we don't worry about that. The only thing we want is that when we're doing that reattachment of the intestines back together, we would prefer the substance that is flowing through this attached area as a liquid area, because if it's solid, then number one, it increases the pressure for the colon to push it out, and so that puts the area where we reattach back together under pressure, and sometimes that will kind of open up, and so we don't want that attached intestine to open up. So as long as it's liquid, we live with it, and that's the max that we expect out.
So, you have talked about the process, but what psychologically a patient have to prepare before? Like, before the surgery, is there any mental or physical, or like you have to prepare mentally also, no? So, what
For
preparation that patient have to do?
for ostomy, you mean?
Yeah, if that
Right.
person is having ostomy.
Yes, yes. So it is as you've heard. Having an ostomy is a life changing event. Okay, it is a life changing event. It's rather hard for most patients to accept that there is stool that's coming out and falling into a bag, as opposed to, you wake up on a daily basis and you have your half liter of water or a cup of coffee or whatever it takes to go to the bathroom, flush it out, and you're done with it, right? So it's definitely a life changing event. Typically, what I do is I go for my Google Mom and open up a few pictures. I show them what a stoma bag looks like. I have some favorite videos that I've had from the Crohn's and Colitis Foundation, CCFA, which is Crohn's and Colitis Foundation of America.org. And so there are some testimonials, and I show those videos to the patients. And it's something that needs preparation. And one good thing is, in the past 2.5 years, Hollister is a company that makes excellent ostomy bags. Hollister guys have a whole team in Hyderabad, and Andhra Telangana for sure that I know of. So typically, I ask these guys to do a home visit before the operation. So before the operation, few important things that I have trained these guys and I have educated in these guys is that you make sure you look at, if it's a female, where they're wearing their saris or their kurtas, and or if it's a guy, where they're wearing their lungis or their pants, you know where the belt line is, you know where the skin creases are. They're able to, some might have a overhanging belly, and you cannot put the stoma bag underneath the overhanging belly, that because they need to look at it. So for that, you need to be able to locate the stoma in sitting position, standing position, so that they're able to see the stoma at all times, right? So those are the issues that I have trained these guys. It's very important to have all of these basics covered before the operation. So I make sure that any patient of mine who's going to get, as long as time permits, and like I said, it's not an emergency procedure, and it is a planned plan. Make them go to their house, give a demo of what a stoma bag looks like, how they empty out, how frequently they have to change it. Just put the bag on the skin, even though there is no stoma. Let them wear it for a day or two. Let them get a hang of what it feels like when, when the bag is attached to them. The bag is basically about 500 or 600 rupees, not a big deal, to try one out for a day or so the day before. So I think that kind of gives them that confidence of, oh yeah, yes, I can do it. And I also have like I said, I also have a few videos where, guys wear a stoma bag and go for a swimming, or they put what we call a stoma cap and they go work out and do the exercises and all of that. So definitely preparing a patient for a stoma is very important. Um, and I think that definitely needs some time to be spent with the physician and the patient, and also with the stoma care person and the patient, so that all of them are in good understanding of what exactly is going to happen, how big of a life-changing event it is, and so that after the creation of stoma, life would get a lot more easier for this, and they'll be able to go with the flow and not have any major issues with it. Right.
So in India, I don't think we have lots of doctors who are talking about this before the surgery. I think there are many patients who get to know about this after they got a ostomy. So how can we improve this situation?
Um,
Hello?
well, it all boils to the training part of these guys.
So your voice is breaking.
Because ordering, arguably, cleaning the stoma has been. Sorry, am I audible now? Better?
Oh, yeah, it's better. Yeah, it's better, sir.
Mansi, better now?
So it's still breaking.
Okay. So, yeah, it's still a huge social stigma in our society.
Yeah.
Wearing a or any stoma bag is still a huge social stigma. And again, honestly speaking, I have had a good number of Muslim patients, arguably because their religion wants them to be very clean before they go into the masjid. So I think that is another reason that most Muslim patients would say, "Doc, please don't talk to me about colostomy." I've had a few patients with rectal cancer
Yeah.
who said, "Leave me alone. I have no worries. If I have to go, my time's up. My time's up. But I don't want a colostomy."
Okay.
Right? So I've had patients like that who did it, and that social stigma is something that is always there. That is always there. So, but again, creating a colostomy is an art in itself, but not just that, but colostomy creation or ileostomy creation definitely needs pre and post follow-up. A good number of times after the stoma is done, patients go, but I typically ask them to come back every 2 or 3 weeks until I feel comfortable that they're able to properly take care of the stoma. I feel comfortable that they're properly able to take care of the skin around the stoma, because if you end up in any of these issues, skin excoriation or pouching issues or anything like that, then patient would be cursing me on a daily basis rather than anybody else, right?
Yes.
So it's very important for me that they feel comfortable, and they also have a stoma therapist who is available for them to be able to take calls. Any meetings that we go to, we definitely, especially in our colorectal society meetings, we have a few hours dedicated for stoma care people, right? And there are usually not only colorectal surgeons, but general surgeons and surgical gastroenterologists and all of these people who are either invited or out of interest. They come in for our meetings, and they do definitely, if they come, they'll definitely learn how to take care of a stoma, meaning how to prepare them, how to create it, how to take care of it after surgery. So it's an evolved science in the West. It's still an evolving science or technique in the East, in India especially. I think it's probably just a matter of time, but pretty soon will be there where we'll have an appropriate counseling and everything available for patients who are going to go through this.
Okay, so next question is, what are the possible complications post surgery and how are they managed? What is the usual recovery time?
Right. So if we were talking about just the ostomy, post-op complications are, so like we talked. If it is the beginning part of the small intestine, like the jejunostomy, or the last part of the small intestine, which is an ileostomy, one thing we need to understand is the contents or the food that we eat is still in a liquid phase when you're in the small intestine. So when you're in the jejunum or when you're in the ileum, the food that is being digested is still in a liquid phase, and about 70 to 80% of that water is absorbed in the large intestine, and eventually we end up having a solid stool, right? So if we have an ostomy that is coming out from the small intestine, the most common complication is that patients would get dehydrated because of the amount of liquid that is going to be put out through the jejunostomy or ileostomy. So that is something that needs to be very carefully monitored. Most of our patients with a jejunostomy or an ileostomy, we keep them intentionally in the hospital for anywhere between 5 to 7 days. Keep a track of their electrolytes, which is like the sodium and the potassium and all of those things. Keep a track of how much is coming out in a 24-hour period, because it cannot cross 1 liter in a 24-hour period, right? So those are the things that we monitor. And as we are monitoring those things, I typically tend to educate the patient on, okay, if one day they had more than a liter, they say, then I tell them, this is what you need to look out for after you go home. If you're doing more than a liter, you definitely need to catch up. So get on some electoral powder or ORS solution, which has not just drink plain water, but drink something that has electrolytes in it. So like the ORS solutions and things like that, depending on how much is coming out, add on 1, 2, or 3 ORS sachets on a daily basis kind of thing. So that is electrolyte imbalance is one thing. Dehydration is another thing. And then if the pouch is not being placed appropriately, then we will have skin issues. So when the liquid or the solid is falling on the skin on a regular basis, or stool is leaking onto the skin, then we end up with pouching issues, which is typically what we call skin excoriation, and that can easily be taken care of with the appropriate stoma care and all of that. And then the two other important surgical complications are, one we call a stomal prolapse, where we create that rosebud coming out of the, if you were to look at the ostomy, it typically looks like the rosebud. If it is protruding out like an elephant nose, then we call it a stoma prolapse. It means that the intestine, whether it is the jejunum or the ileum or the colon, the extra length is kind of protruding out. So that's called the stomal prolapse. Or sometimes what we call a peristomal hernia or a parastomal hernia. So, like I told you in the beginning, we make a hole in the muscle and bring out the intestine, right? So, it is an artificial hole that we have created in the muscle wall, right? So, because of the artificial hole in the muscle wall, as patients age, or some patients who have chronic problems with coughing and things like that, the opening will widen up. And so the normally where the stoma has to be nice and snug, the opening will be wide enough, and then you have other parts of the intestine that try to protrude out. So then the whole stoma skin will kind of bulge out, and then you will have like a small stoma bud that's looking out of there. That also causes a lot of pouching issues
Yeah.
because the bag is not able to sit properly and things like
Yeah.
that. So surgically, these are the two things that definitely will need correction, which is stomal hernia and parastomal hernia and stomal prolapse. Rest of all the other things, definitely we can manage them medically, so that all of those complications can be straightened out with medical.
So, if some patients' stoma is not made properly, can another surgery be done to make that stoma properly? Like, can we do
Yes,
another surgery also?
yes,
Okay.
yes.
So, it can be done.
So yes, so typically we do that. That's what we call a revision of stoma. And the most common one that would require stoma is a stricture of the stoma, right? So one of the other complications that I forgot to mention is when we create this rosebud, it should be nice and open, as opposed to if the skin contracts and then the opening of the stoma narrows down to a point where you're not even able to put in your little pinky finger to the stoma, then we call it a stricture. What happens? Blood supply intestine is compromised. So, like I told you before, when we create the stoma, and that we maintain that blood supply and bring it out of the stoma. And so, in creating that, if the blood supply for one reason or not, or the other gets compromised, then the stricture happens. Good number of times we just go around the stoma, again, bring it out some more, bring it out some more, maintain the blood supply and revise it and be able to do it. About 10% of the times we might have to open the stomach or sometimes do a laparoscopic surgery, and through the help from the inside of the abdomen and from the outside of the abdomen, a combination of in and out, we will be able to definitely revise the stoma to make their life much better. Right.
So, can you talk a bit about Ilios, which occurs in some patients after surgery?
Right. So Ilios is again, if you were to talk about it in plain English, basically the intestines are just sleeping there and doing nothing. Right. So normally your small intestine or your large intestine, their action is continuously or constantly keep moving like an earthworm and keep moving the intestinal secretions downstream always. Typically, Ilias is something that we see in most commonly in emergency operations. So when we're going for emergency operations, patients are sick. There's a lot of infection or pus in the intestinal in the abdominal cavity, and so what is Mother Nature's response to that is the more the intestines move. Let's say there is an intestinal rupture. The more the intestines move, the more amount of leakage is going to happen from that rupture. So the Mother Nature has created our body in such good way that when we have an infection in the abdominal cavity, then the intestines lazy out, meaning they stop working because they don't want to push out any more of that infection, right? So they lay there until things are settling down, settling down, settling down. And once the kind of settles, the activity of the intestines starts back again slowly. So that period of where the intestines are sleeping completely is what we call technically Ilios.
Okay, so, what are some precautions that the patient must take after the surgery for quicker recovery?
Um, Nutrition, very important. Okay. Now, another myth in India is, food restrictions. They say, you eat dal and you're going to get pus, and you eat this, and you eat curd and you're going to get. All of these are myths, right? We know for sure that source of protein. We know for sure curd is an excellent source of probiotic. All of these things are good for health. So I make sure that I tell all my patients there is no such thing as restrictions of food or any intestinal operation is done. The only thing we want you to do is eat in moderation and definitely add plenty of liquids to whatever you eat as a good protein food. But typically, there is no restriction. Nutrition is very important because without nutrition, the body will not be able to recover quickly from whatever insult we have done. Basically, we as surgeons are insulting the body on a daily basis. Doing a surgery is an insult to the body, right? It's an artificial insult that we're doing. So, for that artificial insult, for the body to come out of it, it has to recover. And for it to recover, it needs calories, and the calories come from sorry. I was getting a phone call. So for the body to recover out of that, you definitely need nutrition. So nutrition is something that's important. Activity is something that's important. Um, Positive attitude from the patient. Yes, okay, I'm over it now. I'm going to be done. So these are the psychological and nutritional issues that will help patients recover big time after surgery.
So, a patient have to take some extra supplements also, like vitamin C, minerals, extra supplements in the form of medicines to cope up with the situation, or the nutritions will do it. Like alone, only the nutritions will take care of it.
Right. Usually nutrition itself will take care of it unless otherwise we have removed a section of a large section of the intestine. So let's say we've removed a long portion of the ileum, right? There will be a B12 and a folic acid deficiency. No, definitely. And those patients need to be on B12 supplements and folic acid supplements for the rest of their life. If a large part of the jejunum is removed, then iron deficiency is going to be there. So things like that. So depending on the section of the intestine that's removed, supplements have to be added on. But if you were to look at the colon, right, good number of times you don't need any supplements. Just normal oral food intake will definitely get you back. Right.
So, as a doctor, would you advocate for counseling of patients going through this surgery, both before and after the surgery?
100%.
So, because in
100%.
India we don't have such concept of counseling before and after the surgery. It's just that after the surgery you get to know about the concept. Before, there's no such guidance given to the patient. So, how can we improve the situation in India now?
Like I said, train the healthcare providers, be it physicians, be it the nurses. Believe me, the best corporate hospital in Hyderabad, Apollo Jubilee Hills, did not have a person who can take care of a stoma before we started as a team, as a colorectal team in Jubilee Hills. Now, after we have established the colorectal team, then we started sending one of our nurses to on a yearly basis and a 6 monthly basis for the stoma care conferences, and then started incorporating this as part of pre-op counseling. And then I started having Hollister guys bug them enough that they need to provide the services. If their products need to be sold, the service had to be provided. If you want to charge for it, please be my friend. Go ahead and take that, but you have to be able to provide the service. So then they also started incorporating and teaching their people. They always have 3-4 reps within Hyderabad who, with a phone call, I give their phone number directly to the patient who is getting discharged from the hospital. So they are in one contact. Any issues, they call. That guy is having issues. He calls me, sir. I am right here. A good number of times I do a video call with that WhatsApp video call with my stomach care therapist. Look at exactly what's happening. So all of this is a, like I said, it's a slow evolving process. Um, something that will take a little time, but definitely something that's going to happen in the
A
near
very
future.
less number of stoma nurses in India also. Like I don't
Right,
think so. Every hospital in India have a stoma nurse also. So
right.
people are not getting that stoma care. Their stoma is getting worse and worse day by day, and they don't know
Yeah,
how to take care of it. So how will even the old generation, they don't know how to do it. So how they cope up with that situation?
true. Um, well, older generation is, for them, creating a stoma is a double-edged sword at that age. It's a
Yeah,
double-edged sword. In some, it's a blessing.
yeah. For young
You
age,
know,
I think it's a blessing.
right, right. Definitely. Um, uh, See, again, it boils down to counseling the patient and the family.
Yeah.
It
So
boils down to the family.
okay. So how can a patient explain their condition to their family and friends? Like how can they explain that they have a ostomy and the process and all?
How can a patient explain it to the family, you mean?
Yeah, friends and family, like the people around them, how they can explain it to them that what is the concept of ostomy and how will they explain to their colleagues or their friends or their family?
Uh, hmm. I honestly don't think you need to express your own personal details to someone. You mean to say if they are having surgery
No,
or
no, no. I'm asking like if I have a ostomy and
yeah,
I'm going to office, I have to tell them that I have this situation with me. If
no,
somebody has some issues related to that, like in case of ileostomy, I think a person has to tell them because you have to go frequently to the washrooms and all. So you think we don't have to tell the other person that we have this problem?
no.
Okay, so we have to
It's
just
not. It's
private.
no. It's yeah, yeah, yeah. No, no, no. I'm not saying hide it, but it's not mandatory that anywhere you need to disclose that you have a stoma.
Okay,
Yeah, no, definitely not. But at the same time, if you have a close friend from whom you need some kind of help, then I think explaining whatever the kind of pre-op counseling and post-op counseling that you've received, most of the times, if there is proper counseling given to these patients, they pretty much understand what's going on. And believe me, I've had a good number of, when I was in US, I've had a good number of patients who would come back to me purposefully and tell me a little trick that they have learned.
okay.
Okay, just so that they would say, "Hey, doc, I want to tell you this because I just hope someone else would benefit from this, and I thought it definitely helped me out, and I would hope somebody else would help me out." I mean, like the one thing that I always forget, and I could never, I always remember, I could never forget is one of these patients had a small parastomal hernia, and he was having a little bit of a pouching issue. So I said, there is something called an abdominal binder, like a Velcro strap binder. I'm sure you might have seen it.
Yeah.
So I told him to use the Velcro strap, and then he used the Velcro strap, and he was putting it on top of the stoma bag, and that was pressing on the stoma bag down on and then he was not comfortable. And then one fine day, you know what he did? He took that faceplate of the faceplate of the stoma bag, made a hole on the abdominal binder, and he took it to a tailor, had it nicely sewed into the abdominal binder,
Okay.
and he would wear the binder with the hole coming right on top of the stoma bag, and that worked like excellent,
Just like a pouch.
right? Yeah, right, and he would put back top that had on top of the stone. It would hernia. So he came to me. He showed me, and things
Making
like that
it.
happens as through. So we learn from you, and you learn from us. Right?
Yeah. day by day we get better only. So yeah. Okay.
Absolutely.
So patients with an ostomy receive disability benefits in developed countries. Should India not do the
Yeah.
same? If yes, your opinion or advice how this can be achieved?
Yes, yeah, stoma is a disability. Like I said, it's a life-changing event for sure, right?
Yeah.
So the disability benefits definitely have to include stoma patients, especially if it's a permanent stoma, especially
Yeah.
if it's a permanent stoma, right? So it's again a political battle. I think that is something that has to be taken up uh, with the admin of whether be it state or center, and kind of advocate for. I think basically it's a human rights thing, so that's where we probably ought to start off to include these patients with permanent stoma as a permanent disability. Yes, definitely.
So how can a patient contribute to make this disability law something like to include stoma patients or ostomy patients into a disability group? So how can we contribute? Like we are doing this, but how can we contact the government or do something for our rights?
No, I see. I think this is basically there is a. I'll need to find out the finer details of that. But what I've known of is that there is a voting mechanism where if we're able to pull up all of these patients who have a stoma and
Okay.
represent to the government that yes, this is the sheer number of patients that you're looking at who have. I mean, maybe we're not asking them for money, but we're asking them to provide facilities
Yeah.
which would make life easier for patients with stoma. So
Yeah.
that could be things like as simple as making sure that there are bathrooms available in places, or making sure that these patients with permanent disabilities have an appropriate or a closer parking space to whether they enter into a mall, or whether they enter in for a ticket reservation, be it a bus or a train or things like that. So that those little things like that would definitely make a big improvement. Like you said, a patient with stoma might not have the time to wait for 3 hours or 4 hours to buy a reservation ticket in
Yeah.
the train station.
We have
So
a reservation in railways. Indian Railways has a 50% reservation, but in other things there is no such reservation. And
right,
also, I think the medical insurance they don't cover the bag charges like the
right.
stoma supplies. They don't cover that. So I think this have to be covered in the medical insurance, right? Because there are many people who can't afford the bags and supplies. So how will they manage it? What are the ways they can do they can manage their supplies, the ones who cannot afford it?
Or the ones who cannot afford it, there are a few charity organizations, but again, the sheer number, it's probably tough to meet the ends of the requirement as opposed to the supplies. A fair number of times I ask my Hollister guys to, if we're sending them patients, 5 or 10 patients on a monthly basis, say, hey, there is this one patient who would require more supplies for 3 months or 6 months, and they can't afford it, kind of thing. Basically, it's word of mouth and charity. Uh, but that's probably one place where some entity or organization will be able to help these patients out with supplies. When we were in the US, you know, patients who did not have insurance also had to
Yeah.
face similar issues. Again, it's the same process in the Western world like it's in the Eastern world. We think of it as a rosy fancy, but I had patients in US who were not able to afford for a colostomy bag, and then we had to call the Hollister guys or Covidian guys and say, hey, I have this one patient, you need to provide them. And then again, it's a huge process from them. They need to write off and and all of that. But things happen, but yeah, at some point or somewhere we need to try and help these patients out. Right.
So in India, we don't have any such data in which we know, okay, fine, this much number of people are there with ostomies. So how will this organization be created where we'll get all the data from hospitals and get a figure, okay, this much number of people have ostomy. So how will this thing be being done in future to make a list or to make a data out of, because people are not willing to share it with other people to give the data. So how will this data be updated in future?
Um, I think starting off from the hospitals where the stomas are being done is probably the best bet. Uh, and of course, there has to be a central registry point, or one place where all the data that is entered goes and lands there, and somebody is overlooking it. And if we're able to do that, and if we're able to not only having the data but communicating with the patients back and say, hey, if you come across anybody, this is our website, and these are the services that we provide, or these are the advantages that you have by logging into our website and things like that. That eventually will increase the size of the community. But I think bottom line, it has to start from all the hospitals. I would say at least the major corporate hospitals in the major cities, and say, hey, we've created this website kind of thing, and it is from be it a NGO or be it a governmental organization, and we're trying to pull up all the stoma data, and I think that's something that will work if we start up from the hospital itself.
Even the Ostomy Association of India doesn't have any data where they can give us the figure, okay, fine, this much number of people have ostomy. So that is a
Right,
major issue, because as a community we are not together and we cannot fight for our rights. So yeah, it's a problem.
right, right, right.
So, in young patients with ostomies often face problems getting into relationships and marriages. So, what advice do you have for patients, and what message would you give to the general population on how they view and treat people with ostomies?
Right. Yeah, like I said, it's a huge social stigma for us. Um, I've had I've had many of these issues. A good number of times I've had the partner come in and talk to me.
Okay.
So I've had a chat with be it the girlfriend or the boyfriend, and say, hey, this is what things are going to be, and let's say he or she has already explained to him or her, and then I sit down as a physician and say, hey, this is something surgically that I did, and if it is something that's reversible, then I'll tell them, right, so he'll need some more time, and it is a reversible thing, and we'll be able to do surgery, put it back together, or no, it is a permanent thing, and this is how he's going to lead his life. But it's not something that he's going to pass on to his kids, or because that's a huge thing in India,
Yeah.
right? Right, passing it on down.
Yeah.
And I don't know how to get that off their mind, but I make my best effort to I make my best effort to tell them, no, this is not something that is going to pass on to your kids. Believe me, your kids will be normal. So again, it all boils down to proper counseling. I've had issues where even the marriage has happened without disclosing to the spouse that there is a stoma, and then
It's a shock for them.
things come to my things come to my door, and then it gets a little tricky, even more tricky for me to try and convince, because why the hell did you hide it, kind of thing. And those are a little tough, yeah, to handle, which I've had to. But I think prior to disclosing, explaining what it is, um, I know in young males or females, that body contour or the figure or the physical appearance is something that that might come into the process. But again, I explained to them there are these stoma caps and things like that you can wear it, you can hide it, you can close it for that hour, 2 hours, x amount of time. So it's all how well you're able to communicate with them. Um, that is what matters. I think that is what
So it was end of this questionnaire session. So it was really nice talking to you. It was a really great session. Thank you for being part of this. Thank you, sir.
matters. Wonderful. My pleasure. My pleasure. No, it needs to. It uh, Right. So again, Nikhil, well, again, let's start off. I don't think that is something that anybody would wants to do on day one of meeting a partner, right? So, again,
Talk.
definitely, 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 Nikhil. Again, see, one fact of the life is that it is a disability, and like Manasi asked that question, we're thinking of asking for permanent disability in these patients, right? So anybody who has a permanent disability, you definitely will get a backlash once you disclose the information. But like I said, the person who has the disability obviously do not have a choice but to have some patience and explain it to the partner, right? If both the partners are having disabilities, it's a completely different situation,
Yeah.
right? Each one knows each other's the psychology, and each one knows how to compensate with each other's permanent disabilities. But if you have one person who's completely normal and you have another person who's disabled, then you have to put in that effort to be able to and one thing I will say, if a person had put in that effort and the spouse is not understanding of the permanent disability, you that person should probably not be involved in that relationship anymore, because that's going to be a life of hell, right? Move away. There is plenty of people available in this country of India or in this world,
You're
and
very
and you will definitely find a person who will be understanding to you. Even if it takes a year longer, I would strongly advise to do something like that rather than compromising for the next 30 or 40 years where you'll have to listen to this on a daily basis. But talk about it. Talking about it, I think properly talking about it, and if need be, taking a professional's help in professionally. I mean, giving not only giving them a bit more solid confidence in what they're hearing from you, but also professionally listening from a guy who deals with it on a daily basis will definitely boost their mental health. I don't. I don't think so. I don't think so. The only time I would say it would affect is if we were to do a cancer surgery for the rectum, which is something that we are seeing more commonly these days in younger males, right? Uh, and cancer of the rectum, 9 out of 10 times will require some kind of radiation and or chemotherapy to the rectal area. That kind of involves a little bit of radiation to the prostate gland and the male sexual nervous processes. And so, and when we do surgery and create an ostomy for them, they might have loss of libido. They might have what we call retrograde ejaculation. They might have some erection issues. So that's something that, technically that we might see. But no, if we were dealing it with Crohn's disease or ulcerative colitis and a stoma, I don't. Right, right, yeah, right, 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 right. Good, good, wonderful. So enjoy the rest of your program. Yeah, I'll say bye. Yeah.
Thank you.